All right, our guest presenter, Dr. Siraj Husain. He's a radiation oncologist at Tom Baker Cancer Center. I Googled him today, trying to get a nice, brief little bio about him, but I couldn't find anything that, and his secretary is away. Now, Dr. Husain has spoken to our group. I think this is your third time? Second or third time. So I can truly say here's a man who needs no introduction. Dr. Husain, would you like to come up and take over?
Well, good evening, everybody. For those of you who don't know me, I'm one of the radiation oncologists at the Tom Baker. I am in charge of the brachytherapy program at the Tom Baker, but I also do a fair amount of external beam. In the other talks I've done at the center here, I've actually talked more about brachytherapy. So this time I'm actually going to switch gears and do a little bit more about the advances in external beam and then touch on brachytherapy a little bit. There's a few slides, so I'm just going to be skipping over a number of the slides, so don't try and read everything that you see on the slide, because what's important on the slide I've just kind of highlighted a little bit. So what I thought I would do from speaking to Bob and sort of getting an idea of what you all wanted to listen to, I'll just go through a bit of the basic understanding of prostate cancer again, especially for some of the new people. We'll talk about some of the risk categories, treatment options, and that'll be actually relatively brief, hopefully. And then I'll talk about radiation treatment as a cure, concentrating more on the external beam, taking you right to the past to when external beam started and bringing you up to date to the present. And then I'll touch a little bit about brachytherapy. So the first thing to do is always start with the gloomy aspects, because then at least you can do something good afterwards, right? So how bad is prostate cancer? I think most of you are probably aware that prostate cancer is the most common cancer among Canadian men. That in 2007, because unfortunately some of the data is a little bit older, there were about 22,000 people diagnosed with prostate cancer yearly in Canada. About 4,500 approximately die of it. If we think on an average, that's about 429 men will be diagnosed with prostate cancer every week across the country. On an average, about 83 men will die of prostate cancer weekly. And if we think of it, 1 in 8 men will develop prostate cancer during their lifetime. The only good thing about that is that most of them will be over 60, and only 1 in 27 will die. If we go back to the past, those numbers were much higher. So we've improved quite a bit over the last 20 years. In Alberta itself, we see about 14,500 new cases of all cancers, and about just over 5,500 people die. On an average, that means about 279 Albertans are diagnosed with cancer weekly, and 112 Albertans die of cancer every week. So it is a fairly big problem across Alberta and across the country. Almost even for men and women now in terms of cancer diagnosis, though a little bit more men than women. And if we think of it, in Alberta, almost even number of men and women are diagnosed weekly, and almost even numbers will die on a weekly basis with cancer. This is all cancers, not prostate, of course. Because if a woman had prostate cancer, I'd be a little concerned. Yeah. So what about prostate cancer stats? Well, in about 2,500 men are diagnosed with prostate cancer in Alberta, and about 430 die from it yearly. On an average, that means 46 people are diagnosed weekly in Alberta. This is all of Alberta. On an average, about 8 men will die with prostate cancer on a weekly basis. 1 in 7 men in Alberta will develop prostate cancer during their lifetime. Though 1 in 7 are diagnosed, only 1 in 26 will die from it. And in Alberta, prostate cancer is the most frequently diagnosed cancer in men. It accounts for almost 1 in 3 of all the cancers that we see in Alberta. So those are pretty harsh numbers in terms of how many people are diagnosed across the country in Alberta itself. So it just emphasizes the problem that we have. So we can say, well, what predicts the outcome of prostate cancer? And if we think of it, we can look at it in 2 aspects. One is personal factors in terms of the individual themselves, and the others are the clinical factors in terms of what we find when we look at the prostate cancer in terms of the grade of the cancer, the PSA, and the presenting clinical stage. The only thing I can say about diet is that the only thing that's proven in diet to aggravate or promote prostate cancer is fat. And it does increase the risk about 2 to 3 times. And that's if you have a high consumption of fat. Now, once you're diagnosed with prostate cancer, there's no clear evidence that fat consumption makes a big difference to outcome. The only product that is supposed to have some benefit is soy products. If we think of the family history, if you've got a first-degree relative, it increases your risk by about 2. If you've got 2 more relatives, it increases your risk by about 4. And if we think of it genetically, usually the people who are diagnosed with prostate cancer because of genetics, it's only about 9% or 10% of people, and most of these are the young people that are diagnosed with prostate cancer. So most of the prostate cancer that we see is not hereditary. If we think of the host-related factors, that's the personal factors. Age is a big factor, of course. So if you're diagnosed at a young age, then the outcome is not as good as if you're diagnosed at an older age, and that's mostly because you have a much longer life to live. So therefore, the chance of you dying from something is going to be a little bit higher. What about the clinical factors? I think you've all heard about the Gleason score. That's one of the most important things, and that's a grade of how aggressive the cancer is. So if you've got a low grade, that's a 1 to 6. An intermediate grade is a 7, and a high grade is an 8 and above. And that's usually when the pathologist looks at the sample that they take. They look at the most common type of abnormality and the second most common type of abnormality. And they score them from 1 to 5 in each category. Then by adding up the 2 numbers, they give you a total out of 10. And if we look at it anatomically, you can see that in a grade 1, the cells look almost like normal cells, but as we go out to a 3 and a 4, the cells don't even look anything like normal cells at all. And by the time you get to a grade 5, you can't even recognize that that's a cell. So that shows you how aggressive those cells will be at a 5 and how the slow-growing ones resemble normal cells to some degree. That's why they're not as aggressive. The PSA is a marker to some degree of how much cancer you have. So if you've got a low PSA, it's a good parameter. An intermediate number is 10 to 20, and anything over 20 is considered to be a little bit of a higher risk. And the last thing we look at is the T stage, or the clinical stage. And I think you've all experienced the good old, what we call the dastardly exam, which is done. But when we do that exam, it's basically just so that we can feel the bottom of the prostate. And that helps to give us a bit of an idea of the stage in terms of what we can feel inside the prostate. So the cancer looks like it's confined to the prostate. It's an early stage. If it's a higher stage, the cancer, as you can see, is outside the prostate in these lower slices. So that's a higher stage, and that means that the cancer has actually gone outside the prostate. So if we combine all those parameters, we group people now into a low, intermediate, and high risk group. In the old days, it used to be stage A, B, C, D. We don't use any of that anymore. We now use the low, intermediate, and high risk category. So the low risk is usually the people with the low parameters. That's the clinical stage, the Gleason score, and the PSA. The high risk are those with the high clinical stage, the high Gleason score, and a high PSA. And the intermediate are all the ones in the middle there, so I've just kind of grouped them all together. So if we put all that together, then what makes prostate cancer a problem to treat? I mean, if it's confined prostate cancer, why are we concerned about it in all the talk you hear about should we not be treating? And the main reason for that is that it's the anatomy and the position of the prostate. It's the location where it's located right below the bladder, between the penis and just in front of the rectum. And that makes it very difficult to sort of get at properly. The blood vessels and nerves are also close by. And if we think of it, the aim is to cure cancer, but since the chance of dying from prostate cancer in the next 10 to 20 years after you're diagnosed is relatively low, we have to be cognitive of all these parameters that occur around the prostate and what effect we will have on it. So if we look at the anatomy again, the prostate, as you can see, is located there. No, this is the end here. So you can see that it's located here, just below the bladder, in front of the rectum, and you can see the penile end over here. A magnified view shows the prostate over here and the urethra that runs through it. We look at it on a side view, you can see how close it is and the urethra that runs through. And from the front, again, the urethra is in the middle. So anything we do is going to affect the structures that are close by the prostate. The other big parameters are the blood vessels that sit on top of the prostate and around the prostate, and the neurovascular bundles, which control men's sexual ability in terms of can we get an erection or not. And when we look at it from an ultrasound inside the operating room or in any other way that we look at it, you can see that the neurovascular bundles on color imaging show up over here, but they can be slightly differently placed. And that makes it difficult because we can't actually identify them either in the operating room or sometimes in doing a procedure such as brachytherapy. We end up overdosing some of those structures, or the surgeon cuts them, which results in all the side effects that you see. The only reason we look at this one for the different zones inside the prostate is simply that if we look at where cancer occurs, a smaller amount of cancer occurs in this little transition zone, and most of the cancer occurs in this back zone, which is why when we do that dastardly exam, we have the ability to feel it sometimes. If we look at it again on an ultrasound, we can identify those structures, which help us for when we're doing procedures such as brachytherapy, because then we can identify and clearly increase the dose of the areas where we know the cancer is and reduce the dose to some of the other areas. It also helps us when they have the ultrasound at the time of biopsy. We tend to be able to put the needles into the areas that we want because we think that that's where the cancer is going to be. So as you can see from all this, it's this anatomy and location that makes prostate cancer a problem to treat. And any of the treatments that we do, whether it's surgery, radiation, brachytherapy, cryotherapy, or anything like that, it is going to affect those critical structures around the prostate. The ideal, of course, is to cure a cancer without any side effects. The reality, though, is that we can't achieve that because of the anatomy and the location. So one option for early stage prostate cancer you've all heard about is active surveillance, and where we don't do anything. And what that really means is that we can monitor the cancer and treat it if the cancer progresses. And the aim is to treat it with the same chance of cure at a later time as at an earlier time. And that's simply what I call the good old procrastination type of attitude that some of us like to take. But the important thing to think about that is that it is just as curative if we do that. And why do we look at active surveillance as an option for prostate cancer? That's simply because if we look at the age of people when they're diagnosed and we look at life expectancy issues, we can see that if you're diagnosed at an age of 60, your life expectancy is 20 years, but 81% of people will be alive at 10 years later. That means 20% of people are going to die from other causes, not from prostate cancer. The average number of people that are alive at 70 are 72%. So 30% of men die from other causes by the time they're 70. If we keep on adding up and seeing what happens as we get older, we can see that at 70, only half of the people will be alive at 80. And if we are at 75 at the time of diagnosis, only 25% of people will be alive in another 10 years. And this is nothing relating to prostate cancer. This is just dying from other causes. If we look at the program that we have with brachytherapy, which you'll see down the line, if we've been doing this for 10 years, we've not had a single patient die from prostate cancer, but we've had about 6 patients die from other causes, such as heart disease or pulmonary disease, and some have developed kidney issues or other things and have died from problems relating to that. So because of that, we all look and say, do we really actually need to treat the problem? Actually, if you're diagnosed at 80, there's a negative chance that you're actually going to be alive 10 years later, which means that there's a higher chance you're going to die from other causes than you will from anything else. And if you're diagnosed at 85, well, forget it. I mean, almost 97% of people will be dead in another 10 years. So do we really need to treat somebody when they're diagnosed at an older age? So those are just things that we're dealing with. There are complex issues. There's lots of other parameters involved in that. And people have to be aware of the complications and the potentials of how it will affect quality of life. But the most important thing is that we need to treat both, the physician and the patient have to be comfortable with whatever treatment that we're looking at if we're doing something like that. So what about surgery? The advantage of surgery is that, of course, it does remove the prostate. The big downsides are that it can affect nerve damage, so it can affect erectile function, blood vessel, bladder, neck, and all the other issues, and it only deals with cancer in the prostate. If we look at it surgically, the surgeon cuts the prostate out here from the urethra. He then cuts the section out from the bladder, and then he has to put it together over here. So he has to pull the urethra back up to the bladder over here. So when you do that, obviously that's going to run into a higher risk of problems with bladder and with the nerves around it for the erectile functions. It treats the cancer, but it does create some other issues also. Radiation is not that much better. I mean, it's a little bit better, but still, it doesn't remove the prostate. It can kill some of the cancer in the prostate and outside, but at the same time, it goes through the body to damage some of the other tissues around, and which creates similar problems. Again, because of the rectum being in close proximity, there's a higher risk of rectal problems, higher risk of urethral problems, and blood vessels and everything else. Brachytherapy is really no different. It's minor surgery, still treats some of the cancer around the prostate. It can selectively target cancer inside the prostate, which is only one big advantage. Its problem is that, again, it will create the same problems, but because the radiation is a little bit more targeted, the side effects are slightly less in all of the aspects. So let's look at external beam then, because we're just going to talk a little bit more about the progression of external beam over the last number of years. So we'll look at a bit of the technology changes, some of the visibility targeting issues, some of the changes that we've seen in understanding radiation effects on tissues, how we've applied that, and where we've now gone to evidence-based medicine. So does anybody have any idea when radiation was first discovered? Sorry, Mary Curie, right? Yeah, when was that? 1800. Well, actually, you're pretty close. So the first time, this is a nice story, I always like to say this. So William Röntgen, who's actually the name comes out to X-rays and everything else, first discovered radiation, and this was an accidental discovery. He was looking at cathode tubes, and what he noticed that a piece of paper, a fluorescent piece of paper, was always fluorescing because of the energy coming out from that tube. So he put objects in front to try and block that energy to see why and how you could stop that fluorescence from occurring. But no matter what objects he put in front, the paper still lit up. So what he did was he put his hand in front of it. And lo and behold, that became the first X-ray ever taken, because his X-ray image was imprinted onto that piece of paper. And that was the first X-ray done in 1895, I believe it is. And you can imagine that once he published that, which was the next year, many advances occurred. Someone mentioned Marie Curie. She's definitely the one who really is the father, or woman father, or whatever one call it, of radiation treatment. She actually took the work from both Röntgen and Henry Becquerel, who first discovered radiation in 1896. He didn't really know what it was. He just noticed that, again, just like the rays from the cathode tube were lighting up paper, he noticed that if paper around these substances created the same issue. So what Marie did is she actually did her PhD thesis on looking at the effects of this radiation or beam structure, and lo and behold, she actually developed all the basic concepts that we have today of radiation. In fact, her first paper described the differences in all the different types of radiation that we know, the alpha particles, the gamma rays, and the beta particles. And this is actually important because well, I'll show you later, but this alpha particle is a Canadian first that you'll see actually later, and beta particles are what we use mostly for the radiation treatment. So when she discovered radiation, her husband actually first suggested in 1901 that radiation could be used to treat cancer. So even though he thought of that, it actually didn't come until 1913. So do you know what the first treatment was that was done with radiation? Actually, the first treatment with radiation, or patient treated with radiation, was actually a prostate cancer patient. And this is how prostate cancer was treated initially in early 1900s. I believe it was 1913. It was radium was implanted into the prostate through the rectum. Glad I wasn't wrong at that point. But But that goes to show that radiation, and it's in fact brachytherapy, this is basically an early form of brachytherapy, started in about the 1913, I believe it was, around that time period. So we've been doing this for just close to 100 years at this point in time. External beam, because again, you took those rays that were developed, and if you increase the energy of them, people found that that could be used to treat radiation. And orthovoltage, or the early form of external beam, first started in 1920s. Modern day beams just didn't come until around 1950s. So this image is actually the first external beam machine that was used in 1921. And if you look at how patients were treated in early 1900s and 1920s, it's almost like images out of the old Frankenstein movies that you see, right? Because you look at those images and say, oh my God, what the heck is going on there? I don't even know if you can actually see the machine except all these wires hanging around. Things didn't really change very much over the next 10 years. You still had patients treated, though they were treated slightly differently. But again, you can see all the wires and tubes all around there. And in 1930s, finally someone decided that maybe we can take out all these wires and everything and put them inside a machine, one single machine, so it makes the room look a little bit easier. But that's 1930. So does anybody know where Canada had a role to play in external beam? Do you think Canada actually had a major role in helping to develop radiation treatment? Yeah, actually, the first external beam machine, cobalt therapy, was developed in Saskatchewan in 1949. In fact, the first patient ever treated with modern day cobalt therapy or anything was in Saskatchewan. The high energy machine was first developed in the 1940s, the Betatron. Saskatchewan actually took this and treated the first patient ever in the world in 1949. Cobalt was developed in Saskatchewan. They actually went to the health people in Canada and got them to help build this machine. And this was built at the late 1949s. The first machine is still on display in the Saskatchewan Museum. But Saskatchewan treated the first patient ever in 1951 with cobalt therapy. So Canada is a big leader in development of external beam. Now, obviously, the US wants to jump in and go on with us. So they developed cesium and tried to do the same thing with cesium, but the energy effects of cesium weren't as good. So that's why that machine never really actually took off. The high energy machines that we know of today, that we use in our linear accelerators, in the Tom Baker and everything that we have, the first patient ever treated was in England in 1953. Was a little boy actually with a retinoblastoma. And you can see the type of machine that they had back then. And it wasn't until the mid-1950s that machines started to advance. But still into the 1960s, the mainstay of external beam radiation therapy was cobalt. So here's Ronald Reagan, if anybody remembers him, actually at the first installation of a cobalt machine in the US. As the external beam with that high energy evolved, you can see that the machines were huge. So patients couldn't be treated lying down, they had to be treated sitting up. So I think of this almost like sitting in one of those electrical chairs, you know. Oh my God, what is that patient going through? So the actual type of configuration of machine that we actually have now came by in around the 1970s. So we're not talking a long time. The external beam, modern day external beam, has really been in existence since about the 1970s. And since then, of course, once those were developed and we could penetrate the radiation more deeply into people, so we weren't getting all the skin reactions that we were getting before, machines have actually modernized to where they are today. So you can see that the machines are now much better. The patient used to actually have to rotate around the machine in the old days. Now the machines can rotate around the patients. And as a result of that, what that allows us to do is treat from many different angles and concentrate the radiation beam in the center so that the skin dose in the other areas is much less. In the 1990s, we've developed further advances with putting a lot of things inside the machine heads that allow us in more ways to conform the beam, which you'll hear a little bit more about, to different shapes and sizes around the patient from different angles. Things are now built inside the machine head so that the X-ray or the radiation that comes out can be manipulated the way that we would like. This is actually all occurring in the last 20 years. Further developments have allowed us to bend the radiation, we can focus the radiations, and by putting some of these things in called multi-leaf collimators, which Tom Baker only probably got about 15 years ago, allows us to shape the radiation beam around the target, which couldn't be done before. So this is actually only about 15 to 20 years old. So all these developments have occurred in the last 20 years. And what that allows us to do is to pinpoint the radiation into to a target that we want. It allows us to actually try and bypass and go through some of the tissues around. We still end up radiating part of the tissues, but we can be more precise in what we do now compared to what was done in the old days. And the most latest development is something called tomotherapy, where you can actually do a CT scan at the same time that you do the external beam radiation, so you can ensure that the target that you're going to treat is actually within the beam that you're treating. So if the target is moved, you can move accordingly. Now, Calgary doesn't have one of these tomotherapy machines, but Edmonton does at this point. This is actually one of the most recent linear accelerators that we put in here at the Tom Baker. So the advantage of all this technology is that we can focus the radiation a little bit better. We've got higher energies. We can penetrate more deeply into the tissues. The machines can rotate around and do things that they couldn't be before. We can shape the beams. We've got all these little collimators. And the next step is now to develop things, or I'll talk about a little bit later, is 3D and IMRT. Image guidance is one of the newer things that's coming up, and something new called 4D RT, which is time-delayed radiation treatment. So for instance, if you're treating a lung cancer, as you take a deep breath, or as you take a breath in and out, the tumor is going to move. So the radiation beam can actually be timed with your breath, so that it will only turn on when your breathing is in the same parameter that we want. So as you're breathing up and down, the machine can turn on and off so that it's not missing the target with you moving. The big advantage is also in that time period from the early 1900s is we've understood more about how tissues respond to radiation, because that's the big thing. If we don't really know how the tissues respond, what are we going to do with it? We've learned more about the different doses that we do. If we do small doses or high doses, how the tumor and how the tissues around the tumor will respond. We've learned more about the tolerances of the normal tissues, and we've developed what we call therapeutic ratios, which allow us to exploit those differences between the normal tissues and the cancerous tissues so that we can maximize the damage to the tumor and minimize the damage to the normal tissues. The big problem, though, is that all this technology doesn't help us if we cannot see the tumor. So the most important thing that I always say is that we have to accurately hit the target, right? If we don't hit the target, we're not curing anybody. Oh, okay. Good picture there, right? I think he's hitting the target there, right? So when I actually first started work as a radiation oncologist, this is how I actually used to treat people. So can anybody see where the prostate is in this image? This is how we used to do it. We used to put dye in the bladder, a little balloon in the rectum, and that tried to help us tell us where the prostate is. So this is where we think the prostate is, but really we don't really know where the prostate is. So because of that, we have to treat much bigger fields, as you can see over here, because we don't really know where the tumor is, and because the tumor is going to move, we have to treat larger tissues. So can anybody tell me where the liver is in this image? Well, I can't, but I mean from an anatomical point of view, thinking of where the spine is and the ribs are, we can guess where the liver is. This is cervix treatment. This is just 20 years ago. Cervix treatment, and how can you tell where the cervix is? I have no idea. But what we used to do was create anatomical little diagrams and project out from both a front and a side view, and we would think that the cervix is going to lie somewhere here because this is what the anatomy tells us in books as to where the cervix should be. But we really don't know, right? We're guessing. So the biggest problem with all this is that even though we can advance technology, the problem is if we can't see the tumor, we're not going anywhere. Even if we try and put atlases on and say, okay, this is where we think things are, we're only guessing. We really can't see where anything is. So this is what we used to do in the old days. We'd take the bony anatomy and we'd just put blocks around that and say, okay, we know the prostate's inside here, so that's what we're going to treat. And what we ended up doing was doing lower doses because we were treating a lot more of the normal tissues, and sadly, we weren't really curing a lot of prostate cancer. Then CTs came into being, and as a result of that, the whole revolution in oncology, or in radiation oncology, actually began. It's almost like saying, it's almost like saying that someone turned the lights on because we can actually now see. So on a CT, we can see the tumor, we can see the prostate, and we can see that the shape is different from all the different angles that we can look at. And that allows us to map out the prostate, the seminal vesicles, and we can see the bladder. We can see it from this angle over here in a magnified view. We can see it from a side view where you can look and say, okay, the prostate is over here. We can see the seminal vesicles here, and we can map it out more accurately. And so just as an enlarged view. So with that, we can create 3D models. So with 3D models of both the prostate, the bladder, the rectum, and the tissues, we can actually now get a much more targeted form of radiation. So now when we put a little beam on, we actually know where the prostate is. And as a result of that, we can take smaller volumes and treat to higher doses. Newer technology is that and this is something we're doing now at the Tom Baker, is that we know that the prostate moves. It moves up, down, right, left, back and forth. So on a daily basis, if your prostate's moving, how do we know where it is? So there are two ways. One is to put gold seeds inside the prostate, and then we take an X-ray every day, and as your prostate moves up and down, we move the radiation beam accordingly. But they've now developed transponders which you can put inside the prostate instead of the 3 gold seeds, and there are machines that can read those transponders. So on a daily basis, as you come, you lie down, you have your treatment, the machine will read the transponders, and wherever your prostate is, the machine will move to where your prostate is. And so it'll accurately give you the dose that you need. And it's just a radio signal, so it identifies where it is. Okay?
When was that introduced?
That's actually just in about the last 7 years. So everything is, as I said, all this development is just in the last 20 years. Okay? We don't have that in Calgary, unfortunately, but it is in a lot of other areas at this point. And the reason for that is that if you look at this anatomy, you can see that the bladder fills differently every day. And if the bladder fills differently every day, the prostate's going to move every day. So if we take smaller beams, then the chances are we're going to miss the tumor. So it's very important that we make sure that we move with the prostate. And we can put the little mark on you, though this is actually all that you see on the body when you're getting radiation, but it's all the technology inside that has shaped that beam to where we want it to go. So what is 3D radiation? Basically it just conforms the radiation beam to the different angles and shapes of the prostate, as you can see, because if we're treating from different angles, the shape of the prostate is different. So all we're doing is shaping the beam from the different angles to target the prostate more conformably. And the difference between IMRT and 3D is that in IMRT, we're not only conforming to where the tumor is, we're also trying to conform to where some of the normal tissues are. So we're reducing the dose to some of the normal tissues and maximizing the dose to some of the, to the tumor. So on a diagrammatic view, the 3D means that, as an example, if we take a tumor like this, which is this black image over here, if we treat from different angles, and we put a beam in from here, beam from here, and a beam from here, you can see that the radiation is going to be higher in the center, but it's actually going to be almost smooth around the tumor. But the tumor can have areas where it's actually, there's no tumor in these areas over here. So with IMRT, what we can do is put in little blocks, because of those little collimators inside the machine heads, as you saw, that can be deeper in where there's no tumor and lighter in area where there's tumor. And we can conform this again to the different shapes. And as a result of that, when the radiation goes through, the radiation is higher in these areas where we have less blocks and more in the areas where we have higher blocks, or sorry, the opposite way around. So as a result of that, you can see now that the radiation dose is higher over here and lower in these areas. So if we look at it diagrammatically, again, the 3D gives us a smooth box, but it's shaped differently from the different angles. And with IMRT, the radiation dose is now tailored to the shape of the different tumor, and as a result, we're not only looking at maximizing the dose of the tumor, but in the areas where there is no tumor, we're minimizing the dose. So that's or intensity modulated radiation therapy, as we call it. So that's one of the newer developments also. It's shaping the beam to the tumor. Again, by using all sophisticated means, we can actually now look at every different structure, and we can see exactly how much radiation dose is going to every structure. And remember, I said that we've now got these tissue tolerances as to what normal tissues can tolerate. We can make sure that the dose to those structures is good. So basically then, from that, we can see that we've developed technology, we've developed visibility, and the next step is evidence-based, so that we can prove that what we're doing is good. So I'm just going to skip through some of these, but basically if we look and say why, in the old days we were treating with low doses, not really curing the tumors, and we knew that if we didn't cure and the cancer recurred, people would fail and people would die of their cancer. And what we need to do is identify who benefits with the higher doses. We also know that people who have a higher risk and unfavorable cancer, they will benefit with the higher doses. And we know that if we give a higher dose, we should overcome resistance that's within the cancer cells. And just as an example, when we used to treat back just almost 25 years ago with 60 gray, 37% of patients would get a recurrence within the prostate. Today, with the 78 gray, only about 10% of people will get a recurrence within the prostate. So we've seen a huge difference in that. And we've proven through numerous studies that the radiation dose makes a big difference. That the higher the dose we can go to 81 gray, we can reduce the recurrence quite a bit. If we go to, these are different centers, just showing again that depending on the PSA, the dose is one of the most important things in terms of what we can do to control the cancer. Harvard then looked at surgery versus external beam, and what they showed that again, if you gave a higher dose of radiation, the results were almost identical between surgery and external beam radiation therapy. This is on almost 900 patients that we did the study on. And again, from other centers showing almost the same things, that even out to 7 years, the cure rates were the same. We've done numerous studies that have shown again that the higher the dose, the better. So when we're giving a higher dose, we also want to make sure that that we're doing it right? That we're not creating problems in people. So we never like to be the first, and we don't want things to backfire on us. Like if we gave a higher dose and we created a lot of problems, that wouldn't be good. So again, when we looked at the outcomes and the side effects of that, the side effects of doing these high doses through all these studies showed that the side effects were much less than what we were doing in the past with lower doses. And that's because of the targeting that we are doing with this high dose. So despite high doses, the side effects are much less than what we used to do in the old days. So we look at some of the side effects we've got from radiation therapy. In the first 10 days, we rarely get much symptoms. Usually after 10 days, we get a bit of irritative symptoms from bladder issues. And then towards the end of the radiation, we see some of the skin reactions and some of the rectal urgency and other things that occur. And if we look at some of the late side effects, such as impotence or erectile dysfunction, again, it depended a lot more on the age. But we found that, again, doing the higher doses, this was much less than what we had with the low doses that we were doing before. So basically, this advance in technology and understanding has really helped us understand and improve what we do with external beam. So just a few slides on brachytherapy for those who are if they don't know much about it. It's a little bit more conformal because radiation is implanted into the prostate. It gives us the ability to do ultra-high doses. It's a shorter time, less recovery time, and less radiation to the tissues. So we can see here what we do is we put a probe into the rectum, needles go through this template into the prostate, and all we do is we drop the seeds and take the needles out. So at the end, you've just got all these little seeds around inside the prostate. And what it allows us to do is give a radiation dose around the prostate. You can see that the radiation to the bladder, urethra, and rectum are much less than with the external beam, where you saw the radiation going all the way through. The seeds themselves are very small, as you can see over here, and they're just basically smaller than a grain of rice. And an X-ray showing how the seeds are distributed within the prostate really helps us conform the dose, so we can increase the dose in certain areas if we want. So just basically just a couple of things. We started our program in 2003. We started with an intraoperative program, so we've actually again shaped the brachytherapy in Canada because we were the first center to go to this intraoperative technique. And we've treated about 800 patients to date. Because we've shown in our early reports that the side effects are much less if we do this intraoperative technique, other centers across North America and Canada have done the same thing. Quebec has moved to the same way that we do it. Toronto's moved to the same way. McGill University, London, Ontario, Harvard, and Memorial Sloan, they've all adopted the same thing that we've been doing now. We treat mostly the low risk, but we do treat about 20% of patients with intermediate risk disease. And forget about that. The doses that we can give with intraoperative is much better. If we look at the ABS guidelines, it's 140, and we can actually achieve around 160, again showing that the higher dose is better. And if we look at the coverage, we can do much better than what the standard goals would be. And again, we've proven in a paper, again, from another center also showing the same thing, Memorial Sloan, that these high doses do benefit brachytherapy patients. If we look at the side effects here are much less with brachytherapy than what we see with external beam. And in fact, if we look at our results and compare them to Toronto, we see only about 1.6% of obstruction. Toronto gets about 13% because they were doing the pre-planned system. Our risk of burning with urination is about 13%, and Toronto has about 40%. If we look at our urinary flare, it's about 4.8%, and Toronto predicts about 25 to 30%. So we've done quite well with that. This slide is just to show you that the irritative symptoms that occur from brachytherapy, almost all are gone by about 2 years after the treatment. And burning with urination, we see a few or 10% at the beginning, but then it drops down to under 5% within the next year or so. Erectile function is a big question. We actually did a survey on our first 500 patients, and what we found is that, let's skip this one, is age was a big parameter. If we looked at the people who were not sexually active at the time of the brachytherapy, the average age was about 68. When we look at the people who, after treatment, were not sexually active, at the beginning they were, but their age was down here. But as time went on, their age crossed the average age of those people who were not sexually active at the beginning, and all the other ones are still doing well with sexual function. So it appears from the first 500 patients that we've treated that erectile function from brachytherapy appears to be more of an age factor than it is actually a time factor. We all say that brachytherapy gets worse, or erectile function gets worse with time over brachytherapy, but it appears that more of that is an age function as opposed to sexual function. So we all know that if we do get problems, that when all else fails, there are other things we can try sometimes to see if that if we can improve things. Just maximizing out the credit card, right? So outcome, basically, I'm just going to flip through these. PSA, actually, one of the things is if anybody who's had brachytherapy, you can see that the PSA can fluctuate quite a bit. So this just shows how much bouncing we can see in the PSA before it comes down. And again, you can see people with really no change in PSA for up to 3-4 years, and then all of a sudden the PSA will come right down. And this is just a function of how the radiation works. You can get the PSA coming down, really bouncing up high, and then coming back down again. So there are all these different patterns that we can see with PSA bouncing. So one of the important things that I tell people is don't worry about your PSA in the first 2 years after brachytherapy, because your PSA is going to bounce all over the place. We've actually only had about 2 people with a local recurrence in the first 500 people, and we've actually had only 7 people with a PSA recurrence in the time. We look at how long it takes for the PSA to come down. It takes about 3 years on an average for the PSA to drop. Then after that, you can see the PSA is almost undetectable in almost all people after this treatment. And if we look at survival from this, we've shown that our survival rates are well over 95 to 97% with brachytherapy. And it doesn't matter what patient we've treated, whether they're intermediate, high risk, or whether it's a Gleason 6, a Gleason 7, what the PSA was at the beginning, whether we treat you with a low PSA of under 6, 6 to 10, or greater than 10. So in other words, that part that I said about active surveillance, we can actually let you go up a little bit before we treat, because we know that your cure rates are going to be identical if we treat you at a slightly later point in time. And the dose. The only randomized study of looking at prostatectomy versus brachytherapy was an Italian study, actually. This is important because even though a small number of patients of 200, if we look at brachytherapy and radical prostatectomy, the incontinence rates with prostatectomy were 18% and 0 with brachy. The leakage issues were 5%, and with brachy really nothing, but the retention is just that after the procedure you may need a catheter for a little while afterwards. We think of stricture as being a problem with brachytherapy, but it only occurs in about 2%, and with surgery about 6.5%. If we look at the erectile function, people will always say that after surgery erectile function gets a little bit better. So we can see at 6 months about 40% are sexually active, but at 5 years 65%. With brachytherapy, again 58%, 78 and 65%. So it still turns out to be about the same at 5 years. And that again is more of a function of age, I think, than anything else. So basically what have we learned from all this? We know that brachytherapy is a good treatment, external beam is a good treatment, that there's continuing data to show that both these treatments really work well. And the next step is to add something like high dose rate brachytherapy. And the reason for that is that's ultra high doses of radiation, because there is data emerging now that if we give these ultra high doses, which is well over the 200 mark, that the outcomes are better in all aspects, whichever way we look at it. And this data from William Bowman shows that survival is also better by giving these ultra high doses. So it's a program that we're looking at starting here at the Tom Baker. We've got the software and the hardware. We just have a problem with our HDR unit, and once we get that up and running or get the facility fixed a little bit, we should be in a position to start this form of therapy. So basically, in summary then, we can see over the last 100 years that these technological advances and these clinical advances really show that external beam and brachytherapy have their separate roles to play in curing and treating prostate cancer, that if we combine the two of them to give ultra-high doses, it may be a little bit better. And if we go as back as 20 years ago, 65% of patients would die within 5 to 10 years from prostate cancer, but today less than 10% will die at 10 years from but it won't actually be from prostate cancer, but from other causes. So where do we go from here? Can we predict the future? So the way I look at it is that we can use a crystal ball. I don't know if any of you are old enough to remember Carmack the Magnificent, the famous soothsayer, or whether we use our little old ladies and go to modernized biometric scans instead of just palm reading to see if we can predict the future. But the only good thing that I'll say is that if we can take a picture of Mars rover, I don't know if anybody's been watching the news, but if we can take a picture like this of an object landing on a planet 34.8 million miles away from where we are, and if we can beam back to us high good resolution images of a planet that's 34.8 million miles away from us, not only in black and white, but in high definition color, where we can see the crater or we can see the Mount Sharp that they call, which is what it's going to investigate for life on a different planet. If we can do all that, and we can dream toys for big boys, as we say, about the future, right? And what about future cities? We can believe all this. We can think about all this. We can think about cities in the sky. We can, imagination has no end, right? So why can't we go the opposite and go microscopic, look at the world of cancer cells at a microscopic point? Instead of 34.8 million miles away, let's try and look within our own body. We can identify cancer cells. We can actually see electron microscopy cancer cells, prostate cancer cells, when they're starved, they actually will eat one another. And that's why maybe with hormone therapy we do see that the PSA comes down, because some cancer cells will die, kill themselves automatically because of lack of food and structure. We've got genetic targeting now. We've developed we can see more about the DNA. We've developed nanotechnology, delivering radiation beads directly to tumor cells. We can put chemotherapy within capsules and target them directly into tumor, as opposed to the way that we're doing today. We look at even more advanced nanotechnology, where we can take little robots and infuse them with radiation so that they can target directly into a tumor, release their radiation or their chemotherapy directly into the tumor, which is really more targeted than what we have today. We can do this now because we have more targeting. We saw the CT scans really helping us, but we now have functional targeting, so we can see where on a CT we don't see anything, but on spectroscopic or PET scans we can actually see things. We can see the tumors much more explicitly than we could in the past. Brain tumors, Hodgkin's disease, any of these other cancers. So with with what I call the genetic code in our hands, the question is, where is the future and where is the next step in development? So I think what we can learn from all this over the last 100 years is that, where is the future? I really don't know, but the only thing that I can say is that the best way that we can predict the future is to create it. And this is basically what's happened over the last 100 years. So basically that should be it.
Thank you very much. I certainly learned a lot. I tell you, that was very interesting. I'd like to, do you have time for questions? Sure. Absolutely. We're going to open the floor now for questions.
Dr. Husain, I'm your patient. I take the BT, and it's 9 months ago. And my PSA is just normal around 4, and then I call you up and say, it's normal. And you mentioned tonight talking about the bouncing pattern of PSA. It does not correlate with the general curve of the half-life.
No, it doesn't.
So what happened? Why? Is there any reason behind it?
Yes, actually, it's always a good question why people ask that. The thing to remember is when we're treating with radiation to prostate cancer, is that we're killing cancer cells and we're killing normal cells. Normal cells have a life expectancy and they're going to live their normal life. As they live their normal life, they're going to keep making PSA. The cancer cells are much more sensitive to radiation. That's part of what I was trying to show, is their therapeutic effect. So what happens is they die off early. So the cancer cells usually die within a year. And what we're seeing over the next 1 to 3 years is the normal cells dying. The way the radiation works is it kills the DNA in the cell. But all that does is it stops the cell from being able to have babies. But the cell will live its normal life. So in the younger person, the normal lifespan of those prostate cells is longer. So that's why the PSA takes a lot longer to come down. It's not the cancer, it's the actual normal cells that are dying at a later point. So for those people with a low PSA, what we typically find is that they have less cancer and more normal cells. So that's why you don't see a big change in the PSA at the beginning, but the PSA drops over time, because those few cancer cells die out and then the normal cells will die out over the next 1 to 3 years. So it's nothing to do with half-life, it's to do with the cell population itself that we're trying to kill. And even with external beam, we'll see the same pattern, where the radiation or the PSA will not come down immediately. It'll take about 1 year to 2 years for the PSA to come down.
Question? I'll go ahead. I had a radical prostatectomy in 2003, and for 7 years my PSA was undetectable. And over the past year, it's resurfaced. But my question really relates to the lab information that people like yourself are receiving. the numbers that I was getting, for example, 0.03, it's pretty low, or 0.05. Last week I had another PSA reading, and the report came in as less than 0.1.
That's right.
Is that the new measurement?
Yeah, what's happened?
Have we elevated what's undetectable?
No.
If it doesn't work, change the rating?
Absolutely. If you don't want to treat, raise the bar, as you say.
exactly.
Yeah. The reason for that is exactly what you're facing. When we see people with microscopic recurrence, which is what you've probably got with the 0.03, 0.05 occurring, that means that there's a few cancer cells that are slowly growing. The problem is there's no real value in treating such a low PSA. So the question then comes, why do we need a low PSA? Why do we need to know about that? We know that someone like yourself, there's no clinical relevance to treating with a PSA of less than 0.1. So that's why what's happened in Alberta is that they've changed over from doing that microscopic analysis where they could detect up to 0.01. They've stopped doing that, and they're now only measuring up to a value of 0.1. So if you're less than 0.1, it doesn't matter where you are in the phase, whether you're 0.09 or 0.01, it'll come back less than 0.01. So that's to relieve a lot of anxiety in someone like yourself or other people that have similar issues, because nothing would be done until the PSA was to exceed that 0.1 value.
Well, at what level would it? I have to speak to my doctor.
Usually from a radiation point of view or from a clinical point of view, all studies have shown that if you're going to treat after a radical prostatectomy, if you treat between 0.1 and 0.2, there's really very little increased benefit. If you treat between 0.2 and 0.5, you get exactly the same results. So technically speaking, if you treat with a value of less than 0.5, that's 0.5, not 0.05, then the results are the same whether you treat with 0.11 or 0.5. Once you exceed that 0.5, the risk starts getting higher that those cancer cells have spread. And so you have to remember that the value you detect after a prostatectomy is 100% of cells that are outside the prostate that could have gone anywhere. So that relevance is very different than a person who's had something like external beam or brachytherapy or radiation of any form, because they still have part of that prostate, seminal vesicles, or something left behind. And as a result, their PSA is never zero. So a small rise in PSA in those people may have no relevance. But a small rise in a person after a radical prostatectomy is quite significant.
Good. Thank you.
Thank you. I've got a question, and I have a comment to this. I had the same thing happen to me just recently in June. I get tested every 6 months. My PSA was always 0.002 or 0.001, very low, undetectable.
Yeah.
Suddenly it was less than 0.1. Well, the anxiety that caused for me and for my wife was unbelievable, because I said, if it moves, as far as I was concerned, after a radical, if something's moving, you could be in trouble. And the thing that I found really interesting was when I went to my urologist for my biannual thing. He said, "Yeah, we didn't hear about it either. A lot of people have been phoning us."
Yeah, really?
So there was a terrible lack of communication there.
Absolutely. In fact, first we heard of it was when we saw the results coming in from patients. We were advised that this was going to happen at some point, but we were never told when it was going to happen. So the first we found out about it was when I went to my first clinic in Brachy, and I used to see these patients with values of 0.01, 0.02, and all of a sudden I'm seeing all these patients less than 0.1. What's going on? And that's when we realized that they had made that change over to that valuation.
So you mean that's change in the measurement technique?
Yes, it's a change in the measurement technique.
I was always under 0.02.
Yep.
And that became
0.1. Yep.
So that's 5 times increase.
That's right.
But that doesn't mean it's increase, it's just a change of...
No, it's just a change in the lowest measurement value that we do now. So if your level is less than 0.1, They're not going to do the microscopic analysis to find out exactly what level it is. They're just going to leave it at that.
But there should have been some information.
I absolutely agree with you, and I wish we had the information.
Increasing the actual PSA, it is a different measurement.
I would disagree. It's not a difference in measurement. It's a difference in reporting.
Yeah, well, actually, yes, your wording is better. Your wording is better. It's a combination of both. They don't do that microscopic analysis anymore. They only do the basic evaluation. So it is a slight different technique, but at the same time, the reporting lowest value has changed. So they do not report anything under 0.1 anymore.
So I'm a lot better than I was last year.
Absolutely. So you don't have, so you won't have to worry about it until your level goes above 0.1, right?
So since when this change in reporting?
This was just actually this year. This year sometime, I don't remember exactly when, but probably just about 6 months ago.
January was
Yeah.
0.02.
So it's within the last 6 months.
Okay.
Yeah.
Less than 0.1.
It's just within the last 6 months that they've done this.
I have a question as well, sorry. about that.
Sure.
The brachytherapy,
Yes.
is that done in Calgary now?
The brachy?
Yeah,
Oh, we've been doing that now for about 9 years here.
Oh, I'm talking about the seats?
Yeah, the seeds is what we do here.
Okay, 'cause I thought that a friend of mine had it done in the States, and maybe he thought it was better to go there.
Oh, wow. Hey, next time he wants to donate 20,000 to the U.S. healthcare system, tell him I could use a Porsche also. No, only kidding. No, we've been doing it for 9 years here. So now we don't do the high dose rate. That's the program that we're going to be starting soon. So it's possible that he went down for the high dose rate, because I know I've sent a couple of people of my own to the States or to Toronto for that high dose rate treatment, because especially with data now showing the survival advantage as well as the control advantage, it's prudent on us for those people who are candidates to have that high dose or ultra high dose, that we give it to them. And so I've been sending a few people out to Toronto or to the States for that.
So for the new program of the high dose treatment, are you going to take on clients with higher Gleason score?
Yes, it'll be higher Gleason scored, higher PSAs. It'll be PSAs up to almost 40 to 50, versus with brachy, with our seeds, we only go to about 10 to 15. And we'll take on Gleason 8s and Gleason 9s also, as opposed to just the Gleason 6s or 7s that we do. And clinical stages, we'll even do T3s, versus with the seeds, we can only do T1 and T2s.
Wow, that's fantastic.
Yeah.
Go ahead. I just want to say, my husband sitting beside me, he said, I'm your patient. And I just want to say and acknowledge to everyone that you are so knowledgeable and you're so responsive to our questions, and really calms all the nerves, and we just have absolute confidence in you. And so good luck with the new program.
I'm hoping to get it up and going. We've got all the equipment here. All we have to do is try and work on our physical structure, and then I think we're ready to move ahead.
When?
That's Alberta Health Services that I can say. We've been actually roadblocked for about a year at this point. We should have started about a year ago. And
money goes, severance, I mean, you don't want it.
No, actually, we have the money. The sad part is that we got, and what I say with clinical trials, and one of the big things about why I like talking is that there are lots of people in Calgary who like to donate money. So we actually have the Alberta Cancer Foundation. This program, the Brachytherapy program, was actually funded by the Alberta Cancer Foundation when we first started in 2003. And it was only 1 to 2 years afterwards that Alberta Health Services took over the cost of it. One thing I can actually say right now, because we're going to be starting another new program, away from prostate cancer, if you don't mind me saying something, in breast cancer. In breast cancer, this program has been so successful that we're starting a new study on breast cancer, where we're going to be implanting these same radioactive seeds into the breast So instead of patients getting 4 to 5 weeks of external beam radiation therapy for their breast cancer, they can come in 1 hour, have one single treatment, and have brachytherapy with these seeds for breast cancer. And again, that's funded by the Alberta Cancer Foundation. They've given me almost $300,000 to start this program in Calgary. So we've got all the approval through ethics and everything at this point. Now we're just finalizing our program, and hopefully within the next 2 to 3 months, we'll be starting that here in Calgary.
Why did they block?
A two-part question.
Yep.
My urologist, I had external beam radiation 8 years ago. PSA is hovering around 2.1. My urologist says, I think we'll probably try giving you brachytherapy seeds. I've had radiation 8 years ago. So that's the first thing I'd like you to comment on. So then the second part is, I said, well, what's the trade-off? He said, oh, it'll kill your sex appetite. So two things don't make sense. Could you comment on those?
Well, first, with external beam, the bottom value of PSA is very different than with brachy. With brachy, we kill actually the whole prostate, so the PSAs are usually almost undetectable or very, very low levels. With external beam, that doesn't happen. And that's, if we go back to the time when you were probably treated, the radiation doses were lower than what we do today. So as a result of that, the average PSA that we see is between 1 and 2. And that's actually the normal low value that we see. I would not worry about doing a single thing until your PSA went above 4. You have to have at least a 2-point rise over your base to even be considered that you may have a recurrence. So personally, I would say ignore what the urologist says. He's not an oncologist. He's a urologist. Right. He likes the scissors. And we actually do the thought processes to figure out what we do. Hey, no, I didn't say that. So.
Does brachytherapy kill your sex appetite?
No, in fact, actually, you saw from the study there that we do see most people do well. Now, some people will have some issues because of the neurovascular bundles and circulation, yeah, right. But we find that supportive drugs work very well. Okay. But if you ask, is brachytherapy an option after external beam? Yeah. That's actually a good question, because it is something that we have not done before, but it is something that I would consider doing. In the 2 patients that we've had with a local recurrence after brachy, we've had 2 in 9 years, I've actually re-implanted them, and by doing a second brachytherapy procedure, and their PSAs are 0 at this point. So they have done extremely well with that second implant. So we could potentially, with external beam, it may be something that we would look at also.
A little bit on the topic, but a couple of questions about ProScar, if I can. Yeah. A guy on ProScar, will he get an accurate measurement on a PSA?
No.
So there's no point in taking a PSA test?
If you're on if you've had treatment and you want to take it to help with prostate size or symptoms or anything, yes, there's a value in taking it. It masks what's going on a little bit, but it's worth it to take. If anybody's on active surveillance, I recommend they do not take any of those drugs, because it masks what we need to look at to make a decision whether you need treatment or not.
In my case, I don't have any prostate problems. Well, apart from the ProScar business, but I just wondered. I heard that it doesn't give an accurate reading on that.
Yep, absolutely.
Okay. The other question in the paper about a month ago, there's a link from ProScar to cancer. Have you heard or anything?
Well, there was that study that was done, the finasteride study in the U.S. some time ago now, and it was done to look to see if that would help to reduce the incidence of prostate cancer. It was a preventive study. And what they did find is that it did reduce the incidence of cancer a little bit, but the problem is that those people who did develop cancer developed more high-grade cancer and more advanced cancer than the ones who, than people who had not taken the drug. And that may again be because of the masking effect of the ProScar. So as a result of that, it's not used to prevent cancer anymore, or it's never been used for that. It's more for symptoms.
Mm-hmm. Thank you.
What are these cells made of? And then what happens after you put it? Like, do they disappear?
Yeah.
Is it
They're radioactive iodine. They're within small little titanium beads that are put inside those little things that I showed you, smaller than a grain of rice. The radiation from that, which is actually a part of Marie Curie's discovery, she actually discovered the half-life effect of radiation. that the iodine has a half-life of 2 months. So every 2 months, the amount of radiation is a half. On an average for any substance, it takes 10 half-lives for it to become 0. So basically 20 months after your implant, there's no further radiation. But the titanium seeds remain there permanently, but they're inert after that.
I'd be curious about how many men have had brachytherapy in the room. Okay.
Pretty explosive group.
How many have had external beam? How many surgery? Almost an even number for surgery and external beam. So,
You missed cryo.
oh, cryo, yeah, how many cryo?
Active surveillance.
Yeah, how many on active surveillance at this point? Just one.
Must be a small meeting,
Yeah.
Ron.
Does the Alberta Health have a set protocol for person on active surveillance?
No, it's actually up to the oncologist or the urologist who's monitoring you. We're trying to develop a protocol and a clinic that will actually just gear for active surveillance. But at this point, it's just in the works and we haven't got it up and running yet. But I would say in the old days, when I first started brachytherapy 9 years ago, 99% of patients I saw actually went for treatment. Today, I'd say about 20% of people I see opt for active surveillance. And I monitor those patients that are on active surveillance. The ones that think they want brachytherapy when the need occurs.
I have the mic. Is it working? I just had one. I mean, it's going to be the last question. We do have to move on. I had brachytherapy 15 years ago. Not in Calgary because it wasn't available, as you said. But I had external beam radiation 25 sessions before the brachytherapy. Is that something that, I know there were studies about the effectiveness or the lack of effectiveness. Is that something that you're looking into at all in Calgary?
No, we haven't done that with the SEED program because most of the patients we treat are the low tier, the intermediate risk. There is, for the high dose rate that we'll do, we will be using a combination of external beam and the high dose rate. But there are numerous data out there about the benefits of external beam and seed implant, and they're still a little bit conflicting. There is this randomized study ongoing at this point in time to compare people just getting brachy alone or external beam and brachy for the low to intermediate risk, and the preliminary data at this point shows no difference between the two. So because of that, we've just been doing brachy alone, and you can see the results from what we've done with 95-99% cure rates out to 9 years after treatment.
That's it. All right. Thank you very much.